Greetings, everyone. I am Dr. Benjamin Schooley. I'm associate professor in the electrical and computer engineering department. I'm one of the newer faculty here. I've been here, well, I guess now a year and a half. I started in 2022 in the fall. And I came just as there was a merger between a IT and cybersecurity department and electrical and computer engineering. My background is information technology. My PhD is in information technology, and that's where my work has been over the years. So I came just as that merger was happening. I'm now a part of electrical and computer engineering, and it's been great. It's a fantastic department. Really enjoy getting to know my colleagues. I love being here at BYU. Um, I was at the University of South Carolina for 10 years before being here at BYU at public university. The Southeastern Conference, the Gamecocks. I was in College of Engineering and Computing there in the field of information technology. I started off as an associate or as an assistant professor and became associate professor while I was there. I was also an adjunct professor of innovation at the School of Medicine and a director of the innovation think tank. So a lab where we created technologies and deployed technologies in the healthcare industry for research and for testing. Before I was at the University of South Carolina, I was at the Claremont Colleges for 5 years. I was at the same time a visiting professor at the University of Minnesota. So I've been able to have some experiences at other universities, and I just love being here at BYU. I believe in and just love the mission and aims and focus of BYU and BYU education. So my presentation today is focused on biomedical informatics, but before I really get into that, just wanted to talk about my orientation about information technology research or in that field. I know there's electrical and computer engineers that are listening to this, but just to start off, research, my orientation, NSF, says it's a creative and systematic work undertaken in order to increase the stock of knowledge and to devise new applications of available knowledge. And the Academy of Engineering says a discovery or research is a discovery of new phenomena and their integration into coherent conceptual models of major physical or biological systems. And this is largely what I do is I create applications from the knowledge that's being created through research and test those applications. Now, as a part of that research, there's a major design component, and so designing the technology and then conducting research on that design. So design. This is from Harold Nelson and Eric Stolterman from their book, The Design Way. And they say a design is the ability to imagine that which does not yet exist, to make it appear in concrete form as a new purposeful addition to the real world. So while I'm creating products or artifacts that are technology oriented, I'm researching to create that and design those artifacts, but also test those artifacts for impact. And so I'm going to summarize that in this next slide, where my research is very focused on being applied into contextual problems. So design and build, test innovations or technologies that are not quite yet out there in the marketplace, may not be out there in the marketplace if it doesn't test well, and assess those artifacts for their utility, for the usability, for the use from individuals for which the artifact was created for. And then I want to, at some point, get to be able to assess the impacts of that technology on people and organizations. So are they actually making some improvement to a socio-technical process or system? So a large part of my work is human factors oriented, human subjects research. So it involves people, as people are the ones that are engaging in the technologies that I create. So I'm interested in how they're actually incorporated in the real world. Now, biomedical informatics as a field, I've been working in biomedical informatics for my career. It's an interdisciplinary field that really looks at the intersection of work and research and product development in computer science, includes engineering, of course, medicine, also includes cognitive and social sciences and humanities because of trying to assess how people think and why they use technology the way that they use, and the impacts that we look at are on the impacts of in the real world, which include economics, might include cost, include efficiency, include things such as that, and because we're in the biomedical sciences, it's the medical and biological sciences that also interact. So it's really at the intersection of computer sciences and medicine, looking at creating artifacts and systems that will that can be used to improve decision making in healthcare. So also within my title is, a focus or a goal of developing the artifacts and products that I create are for accomplishing patient-centered care goals. So patient-centeredness is a paradigm that has been a focus of our healthcare systems, not just in the United States, but in many places around the world, of really trying to focus care on the patient themselves, which may seem very obvious that that's what we want to do. But anyone who has had an experience with medical care, especially something very significant, a surgery or a hospital visit, they know that medical systems are often inundated with protocols and processes and policies. And sometimes you ask, hey, well, why do I need to take this medication? Or why am I getting transferred to this room? And the answer is, well, that's our policy, which can often detract from what is really most helpful for a patient. So the three areas, so there's really 7 goals or 7 aims of patient-centered care. There's 3 areas that my work has really focused on, and that is having full transparency and fast delivery of information. That's so that the best decisions can be made based on the most available information, current and accurate information. That care is collaborative, coordinated, and accessible. So we once had a more paternalistic healthcare system, right, where the doctor knows best, and you go to the doctor and the doctor tells you this is what you should do, and you say, yes, sir, yes, ma'am, and you go and do it. But now with the availability of information about medical conditions and procedures and care processes that are just available on the internet, there's been a much bigger push towards a more collaborative decision-making model, which is that patients and doctors, consult with each other to come to the best decision for the patient. which is also the family is included in those decision making, in that decision making. So these are, so you'll see in some of the examples that I give, which I'm going to give here in just a minute, with some of the technologies we've created, this has been a focus, or this is the paradigm that we're really building off of. So computing artifacts are conceptualized in biomedical informatics from an engineering standpoint, which is asking that core question: can we make it, or the technology, the artifact, or can we make it or that artifact better than what currently exists? There's a human-computer interaction component, includes people. People are the users of technology, which could be physicians. In some cases, could be patients, and others could be nurses. But a core question is, does it or the artifact work well for people within their specific context? And then the medicine and healthcare oriented questions are, what is the impact on people and or processes? So is it helping a decision process? Or is it ultimately having an impact on an individual? Is it improving that person's health in some way? So these so triad of questions are what are inherent or a part of each of the projects that I participate in. So some example applications that I've worked on and continue to work on are, one is COPD, so chronic obstructive pulmonary disease. It is a disease that affects over 30 million people in the United States. Many are underdiagnosed, many are overdiagnosed, but it is a progressive and irreversible respiratory condition. What is typically done to diagnose and monitor this condition is, you see this individual is blowing into a spirometer and doing so in a doctor's office. So blow into this device, and the device measures the lung strength and lung capacity, and the patient gets a baseline measure of their respiratory function. Well, the patient will come back perhaps a month later, 2 months later, may breathe into this barometer again, get another measurement, and after that period of time, the patient hopefully has not digressed in their condition. But if they have, then hopefully they can continue to maintain their new baseline and not get worse. What is really helpful in this context is if patients are able to take their readings more often, they're able to be monitored more frequently, and if they're able to be assessed for an impending or potential or probable exacerbation, which is a medical condition or a medical situation where the lungs are undergoing a difficult or a challenge with their breathing, a very significant challenge with their breathing, and after the exacerbation or during it, need to go to the emergency department, and then their condition has regressed at that point. We want to prevent that. So what we have done is we've created a remote patient monitoring system, an RPM system. And what it is it consists of a spirometer that is a handheld that patients can take home with them, and a mobile app that communicates via Bluetooth with that spirometer. And the mobile app walks the patient through their breathing exercises, takes the measurements, and pushes that data directly into the doctor's office, so that the doctor's office can see those readings as often as the patient is taking them with their device and mobile app. And so what this has provided is more frequent measurements and the ability to assess trends in those readings to be able to predict than a exacerbation or a potential exacerbation, and reduce emergency department visits. So the doctor is able to see on each day of the week where those readings took place, and is able to see some self-reported measurements as well, whether there's different symptoms such as coughing and wheezing, chest pain, shortness of breath, and able to, based off of these readings, assess whether that patient should come into the doctor's office, go to the emergency department, or whether their medication should be changed. So this is all available in a testing phase at this right now. So we went through a design phase where with pulmonologists at the Medical University of South Carolina, to internal medicine doctors, some respiratory therapists, and design meetings where we created requirements and prototyped the application. We went through several iterations of that to get to a pilot test implementation. Adherence to the application was good, and we found no exacerbations during that period through the monitoring we had. And we are getting ready to do a larger implementation of 50 patients with one outpatient clinic with a pre and post study design. So we know that the technology is functioning. The usability has tested well. The decision-making processes are much faster and much faster cycles than what currently exists. And so now we're at a phase where we want to understand if it's making an impact on patients' health. So just to follow that cycle. Now here's my framework for R&D that I follow in design science research. On the right side, we've got a typical research process. We've got research ideation built off of theory and formulation of research problems, and empirical research questions. We design an artifact and evaluate that artifact. On the left side is an iteration validating that product in cycles. So one of first, in the formative phase of creating our system, our software and hardware artifacts, are to understand the requirements, the context, the stakeholders, and align the problem with theory and design. So looking at prior research and what does prior research say about how to go about solving this problem if there is available research. Once we've created that artifact and we assess functionality, usability, and acceptance of the functionality, we know is very much engineering oriented. Is the algorithms working properly? Is the technology working properly? Is the code efficient? Then we get into the human component, which is the usability, efficiency, effectiveness, and satisfaction of a technology, and is accepted and used. We then assess impacts on process and then people. So I apply this a number of different ways. I'll go through another example that I have. This is pre-hospital to hospital communications. So emergency medical services. You see this ambulance on the left-hand side is considered a pre-hospital care. And as we know, in our US system, we have a medical emergency, we call 911. Perhaps fire shows up, ambulance shows up. They are doing some level of treatment on scene for a patient. Do what's called a scoop and run, pick up that patient, put them in the ambulance, take that person to the emergency room, and then treat that patient more definitively in the emergency room. So we know this is a very large system. It's a safety net system that we have, and there's many medical emergencies that happen around the country. So as we were looking at the process, there's multiple different kind of organizations that are involved in a single incident. There's 911, there's fire, there's ambulance, there's hospital, and there might be multiple hospitals. If you have to go to one and you need a larger, more capable hospital, then you're transferred to that other hospital. So there could be multiple organizations, but that information doesn't always travel along with the patient from one point to the next. We found that less than 44% of relevant patient information is provided to the emergency department that is collected on scene by paramedics. And there's a lot of reasons for that. Very fast environment if it's a trauma or a stroke. And so it can be very difficult to collect that information. There's quite a bit of research and development that needs to be involved in just automating the data collection in pre-hospital. And there's work that's being done. But that data right now, and for the most part, very little of it gets to the emergency department. We also find that a complete patient record from pre-hospital, from an ambulance, is only available to the emergency department less than 50% of the time. So come through the doors with a patient on a stretcher, and at that point in time, there's a handoff, and the doc or the charge nurse is saying, okay, what do we got? And at that point in time, there's some information transfer, and depending on the emergency level, there may not be a lot of time to communicate. And often a complete record of what actually happened on scene doesn't happen until 42 minutes after the patient has arrived. And of course, in very, very critical situations, that's pretty late. So we want to look for a way to improve the communications, which are largely radio-based, still today are radio-based. Started this work a number of years ago. So we built an application with a mobile app for medics to be able to collect a wider range of information on scene. So they can collect pictures with the camera, audio recordings. They can record video if they want to, though not many use video because of the time consumption requirement. And basic data points that are very easy to collect in a user interface. And this data is all sent to the emergency department as it's collected. So it's an asynchronous communication as opposed to obviously the radio where you need someone on the other end, otherwise the information is not being transmitted. And there's quite a bit of security requirements involved here. All of the data must be encrypted. It must be deleted even after it's been sent, encrypted on both ends. And so, and it's got to function very efficiently as well. So we couldn't have the encryption really slow things down. So a lot of different work is involved in trying to create an environment where data could be sent and received effectively and efficiently. So here's an example record of an actual individual where this application was used with personal identifiers marked out. But this was an incident that happened in Idaho. It was a crash. It was a vehicle crash. The individual was immobilized. And it was counted as what's called a level 3 trauma, motor vehicle crash. So some of the pictures from the crash, upon first look, it doesn't look too bad, like maybe not in the most critical emergency for those that are in the emergency department, until you see a picture of the windshield with a spider web crack, which indicates that the head hit the windshield, which would indicate a much more critical situation with the head hitting the windshield and creating a greater trauma. So we've got, we have the estimated time of arrival, the emergency practitioners in the emergency department were able to see 11 minutes before arrival, which may not seem like a lot of time, but for standing up a trauma unit in the hospital is time consuming. So that's 10-minute savings for what could be a very critical head trauma in this particular example. So we did conduct a field test on this. There were 1,712 incidents where it was used. 100% report availability, meaning the reports actually got to the emergency department every time. We showed that the average use was about 97 seconds and compared that to a target radio report time is about 30 seconds. So the utilization time is quite a bit longer for this app, but the usage is asynchronous. When the paramedic has time to use it, they'll use it as opposed to the dedicated time required for a radio. It's not exactly comparing apples to apples. Our pre-test reports before the application, 46% of reports were sent to the emergency department, and as a part of our test, we improved that to 78% of incidents were reported. New capabilities for decision-making with multimedia. Radios can't send pictures, right? And it can't record the audio as well, which can now be listened to over and over again. And we found a reduced time to treatment for trauma and stroke, very critical items. Another example that I'll run through is orthopedic treatment decision making. So switch directions here. The challenge in orthopedic surgery is that there's quite a bit of heterogeneity in treatment decisions, meaning that there's that there isn't a lot of uniformity in how decisions or different treatments are done across the country. So our analysis that we did about frequency of orthopedic surgery across the country is that surgery rates differ drastically, and from down to 10% up to 40% for a rotator cuff surgery or for a knee surgery. That's a huge span, and so we tried to understand the reasons for that and did some research on that, and with the medical team I was working with, and we found that the difference or the reasons for those differences were really in how the orthopedic surgeons were trained or where they received their specific training. So all those that received training at one location, residency, were more aggressive in their surgery, and in other places where they received their training, they were less aggressive. But they're not much uniformity. But there is consensus that there shouldn't be that kind of heterogeneity. There is little consensus about the best treatment for a wide range of orthopedic conditions and how treatment could really be improved. So what we've done is we've tried to assemble, in this case, a wide range of data. So into a data store. So of course we want records, so past treatment decisions for patients over 10 years. Patient preferences, so what patients actually want as an outcome for their surgery. Do they want to be able to recover well quickly? Do they want to have a low pain? Do they want to just get back to work quickly? We needed to have data into our data store on patient clinical treatment outcomes. So what actually happened as a result of surgery over many patients for 10 years, and then what the patients said about their outcomes. So pulling these all together, this data together, the idea was to create patient cohorts and to do so in an automated kind of way, so that we could compare patients like the one who is sitting in front of a physician at the point of care. So doctor is with the patient. The patient is a 45-year-old male with a rotator cuff tear. and it could go and search and filter for patients similar to that one and have a discussion around the best treatment for that patient. So really aimed at targeting and personalizing a treatment for a patient. And so this was our first step, is pulling together a data set so that could take place. Now this is similar in concept to recommender systems that have been around for a long time. Recommender systems like Netflix and Amazon and other consumer applications used to recommend something to buy or music to listen to or a movie to watch. These recommender systems are based on four real primary inputs. The explicit notation of preferences by the user. So what does the user want? The longitudinal record of the user, so what that user has done previously, what movies they've watched previously. The longitudinal record of all users who are similar to the index user, so other users who are like me, who what movies have they watched, and perhaps that could create a recommendation for me to watch something that they would be interested in. And then my satisfaction ratings. And so these come together to create a recommendation for something like watching a movie. Now for healthcare, it's much more complex because the decision isn't just impacting or isn't just about one individual. There's a doctor who has to make a decision and a patient who has to make a decision together. So there's a negotiation component that has to take place before any type of automated recommendation can come up with. And currently, individuals or people are averse to automated, probabilities or recommendations that come from AI for healthcare. Probably a matter of time before that changes. But we needed to collect patient preferences, and so we determined what preferences those would be. So a outcome preference for a patient when a physician talks with the patient and is talking with them about the type of treatment that they would like to have. They say, well, what would you like to have as an outcome as a part of your treatment? Would you like the treatment to reduce your long-term pain after treatment, improve your functionality, limit your out-of-pocket expenses, so it'll be less expensive, minimize the time requirement for treatment and rehabilitation, or limit the pain and discomfort you feel during treatment? And so on a sliding scale, patients are able to include this information as an input into a recommender system and compare that with how other patients have rated and the ratings of those patients, inclusive or also taking into account the clinical outcome for those patients and the type of surgery or non-surgery physical therapy that they had. So we've created an interface that a doctor and a patient can look at together, accumulating this information and presenting it visually so that the doctor together with the patient can answer these questions. So how did the surgeon treat other patients that are similar to you? So you have a filtering ability to filter down to a specific type of patient. In this one, we have a female that's over 45 years old and has a proximal humerus fracture and has osteoarthritis. So narrowing that down to other patients like this one, how did the surgeon treat other patients like this one? How did the surgeon's peers treat patients like you? How satisfied were patients that chose the surgery versus conservative treatment, comparing the two? The majority of them more satisfied with physical therapy or with the surgery they received? And what were the outcomes for patients that chose surgery versus conservative treatment? So these having the data presented in this way allows for a discussion and decision making between the patient and physician on what direction to go as far as surgery or non-surgery. So I'm at 35 minutes here. I think I'll go through one more example that's more of a larger societal kind of issue that we've addressed. The orthopedic surgery is about personalizing medicine and decisions to a very specific patient, whereas this next topic is about a larger societal kind of impact. So the challenge we are all aware of, we know that in our country, we have an epidemic of pretty massive proportions, and it's the opioid epidemic. We have many overdose deaths. We have many more ER visits as a result of opioid use, and not all of this opioid use is the result of drugs that are being sold on the street, although there are many of those, fentanyl being a well-known one that's causing a great deal of harm. We've also had an epidemic that has been detrimental for just your patient in the hospital. So for an individual who goes through surgery, too many of those individuals receive opioids in the hospital, take them home, and then become addicted. And they may continue to search for prescription drugs due to their addiction, or they may combine those prescription drugs with then drugs on the street because of their addiction. And so that's what these two graphs are showing. On the left-hand side is overall deaths over time from opioid use. And on the right is specific to prescription opioids. There's been some decrease or lowering of prescription opioids without any other opioid, which is good, but there's been an increase in growth in prescription opioids in combination with synthetic opioids, so that are more easily accessible. So it continues to be a major problem. There's a number of different ways to try and solve this, and one way or a few ways that we're doing so with technology. One is we've created an algorithm provides for an opioid prescription guide in the hospital. So these are individuals who have gone through surgery. They need pain management, and but yet at the same time, we don't want to create an addiction. So we've created a guide whereby, based on the amount of opioids that have been taken during the surgery and directly after the surgery, how much or how many pills should be taken home with that patient to reduce the chances of opioid addiction. And so this is much more algorithmic and built into the electronic health record in a hospital EHR, EMR, electronic medical record system, available when the physician enters the patient's room, is going to discharge that patient, create prescriptions for that patient. The opioid guide is used to suggest the amount of pills that should be taken. Another way that we're addressing the opioid epidemic is through a client support system. So this is an application that's used by what's called peer support specialists. These are individuals who have had addictions in the past and are now helping individuals who would like to go through recovery to recover from substance use disorder. It's the Alcoholics Anonymous kind of model. There's tracking that needs to be done. There's assessments that need to be done, and we developed a software application that does those. Now, what we've done is we've connected this software application that has a record of individuals that are going through recovery. And these records are securely available to emergency departments, where if an individual or if a patient comes into the emergency department, the emergency department can query their database and see if this patient is being treated for opioid addiction. And if they are, in the emergency department, they will treat this patient very differently. Example, if it's a possible overdose, then the emergency department doesn't want to give additional opioids. They may be able to immediately give Narcan, a drug that helps with someone who is having an overdose, and it changes the trajectory of treatment for that individual patient. So, so this is a application that works largely behind the scenes, but there's a user interface within the emergency department. There's algorithms that we needed to create for determining the patients to push to those databases and the data to see, and quite a bit of data security to comply with information security requirements. So what we've found is reduced time to treatment for these patients. And there's more accurate information in the ER about potential opioid-related ER visits. And the application itself is enabling individuals to receive the treatment they need in order to help them get back on track with their lives. So with that, I'll kind of sum up. I've found over the 15 years of building these various applications and testing them in the real world, there's quite a bit of software development that has to happen, software engineering, different technologies that are applied together to create these artifacts, but doing so in a rigor, with research rigor and with constructive field testing, we're able to really kind of see or try and determine an impact, and see this really as a valuable strategy for determining societal impact of our research. Back to this slide that I presented early on. Again, this process is designing and building and testing IT innovations, initially testing the impacts on or the usability and utility on people in order to then provide a baseline for moving towards impacts on people and organizations and society as a field study. Often in engineering, you may not want to get into the dirty, messy research involving human subjects and people, but it's an area that I've found meaningful in order to really try and make impacts on the real world. With that, thank you for having me. I appreciate the opportunity to present, and if you have any questions, please feel free to email me.